Want to welcome a good friend, Dr. Ravul Jindal from India. He is the Vice President for the IUP and past President for the Venous Association of India. He's a rising star in venous diseases. Thank you for agreeing to do this podcast.
Thank you, Anil, for inviting. It's a great honor.
So, can you tell me a little bit about this new project that you're working on in India, looking at ulcers in the lower extremities?
Yes, so we don't have any study from India looking at what is the incidence and how actually we treat in India and what all dressings we use, what male or females are involved, and actually what is exactly the cause of venous ulcer in India. Because we always used to go into the meetings and everybody used to say that the most common cause of venous ulcer in India is post-thrombotic. So we put up this project like 4 years back, and we involved 10 centers from the country. It was under the aegis of Venous Association of India. So where we will look into all the walk-in venous ulcer patients, and we'll check up the routine practice in the 10 top centers in the country. How 10 centers they look after the patients with venous ulcers. What are the sex determinations, like predictions are there? What are the causes of varicose veins? And how do we treat it? When do we do the treatments for them? Do we do an open surgery? Do we do laser, foam? How many people do 4-layer bandaging? All those things, we want to look into it. So we have actually closed the study. We are analyzing the data now, and I think another 3 to 4 weeks we will have the full results of it, and then I will be very happy to share those results here, and we will hopefully have a good publication out of it.
So it sounded like you had you learned some things along the way also running this study, because running this study in a country like India is difficult. This is groundbreaking work, and
Yeah.
this is really important work, but it's also a learning experience. So, what did you learn running this study?
I think the things what I learned during the study was, one is when you do the studies, you like country like India, where physicians are not uh, very enthused in entering the data into the paperwork. One should have the paperwork very small. It should not be more than 15 to 20 questions, one. And we had actually 100 questions. So I think that's what we learned. Second is we should involve the centers with the people who are academically oriented and who are actually willing to, go extra mile to fill in the data, because we had 3 to 4 centers who actually didn't contribute anything to the study. So which I learned. Third, I learned is that the completion of the data. I think we should check up along the way every month that the data is completed or not. And we are not epidemiologists, so these are as a clinicians we learned this in a hard way this time. And we didn't actually hire any professional bodies because we didn't had much funds who could run the study. So we were running it ourselves as a Venus Association of India. So that was slightly a lot of things we learned. And we also learned from the project that the varicose veins in India, they mainly happens because of varicose veins, the venous ulcers in India, not because of chronic venous disease or because of the DVT. So, which is a very, I think, important finding. Out of 900 patients, we are going to analyze 500 patients who have completed 3 months follow-up. And two-thirds of the patients had a venous ulcers because of varicose veins. So, which is a very important finding. Also, we always thought that obesity does not exist in India. It's most of the people are thin. Obesity was one of the very good factors we found. Multiple pregnancies, we found another very important factor. And we found more females, had venous ulcers, and but more male presented to the clinic for the treatment for venous ulcers. So that will be another very important social economic thing to look into it, and spread the awareness that they should get early. Another thing what we found that most of the patients they come very late, so which is very bad. And we also found that people use multiple methods before they come to a vascular surgeon. So they use really very fancy things like an homeopathic, leaf treatments. Then there are multiple chemicals they apply. Some people apply the quines with the leaves. All those traditional old things, people put it on the venous ulcer. So that's why most of the patients who came with venous ulcer, they had a cellulitis, and the culture showed multiple organisms out of those venous ulcers. So, which is important, I think, findings by which we should be able to create an awareness campaign of telling the patient that what not to use on these ulcers and what to use in these ulcers. So I think it's going to be very interesting data.
Do you have any idea how large the ulcers were, or
Yes.
because the reason why I was asking is you said they're quite advanced, and sometimes in the Western countries we tend to get ulcers that are 2 by 2 centimeters. It sounds like that's not what you encountered.
No, what we did, we didn't took an ulcer more than 20 centimeters. So we had, but we excluded it from the study because our study follow-up was 6 months. So we knew that such big ulcers will not heal up in such a short time. So most of the ulcers we took was less than 20 centimeters. But most of the ulcers, they fall into the categories of more than 5 centimeters and up to 15 centimeters. So they are big. Uh, but very few ulcers were less than 2 centimeters. Very few. I cannot tell you the exact percentage because I still haven't analyzed that end of the, all that data which is critical.
I think this is going to be groundbreaking work, quite honestly, with 1.4 billion people in the country of India, having new data and developing these new techniques for looking at data,
Yeah.
such as this registry, is really going to be important going forward. Because it sounds like if you can set up this registry, you're going to be setting up other registries.
Yes, I will need your help definitely. And we are thinking of setting up two important projects in the future, and very soon. And one, I want to look into exactly what is the incidence and prevalence of chronic venous disease in our country. We don't know. So we got only 3 or 4 publications with 100 patients, 150 patients. That's it. And I think we need this study, and which I want that it starts in this year, and so we finish by end of next year, and so we have some good results out of that. And we also want to put up a study on looking into what is the cause of DVT in India, because a lot of people look into it like this is the cause, that is the cause. But what I have realized is that in India, a lot of DVTs happens because of interventions, chemoports, lines, permacats, dialysis lines in the groins, and a lot of people get DVT because of malignancy. So I think malignancy-induced DVT is also not behind. This is my clinical observation, so that's why I want to have practical data out of it, so that we have at least some results. You know.
I want to congratulate you on this. I think this is important work, but it sounds like you partnered with the Venus Association of India, which I think is important to not only develop these types of protocols with a larger association and multiple institutions, but also trying to highlight the need for research in developing countries
Yes.
is quite pressing because there's so many patients that don't have access or don't get the treatment that they really do need. So
Yeah.
looking at these issues, especially with venous ulcerations, which is quite morbid, quite costly,
Yeah.
and chronic and recurrent.
Yes.
So I think those are actually really important aspects that I think will help not only India, but many other countries.
Yes, definitely. Definitely.
Congratulations. We're really looking forward to the upcoming presentations and publications of this database. It sounds like you have some really exciting work underway. Setting up this type of registry is tough, but this is the beginning, I think, of much more data coming forward.
Yes, sir.